Hello, and welcome to Public Interest Podcast with your host, Jordan Cooper, where we interview politicians, activists, advocates, and others who seek to improve the state of the world. This is episode 120 with our guest, Gene Ransom, the CEO of MedChi, the Medical and Surgical Faculty of the State of Maryland. It's the state-level affiliate of the American Medical Association. Gene is also the former president of the board of Queen Anne's County Commissioners. Gene, how are you doing today?
I'm doing great. Thanks for having me today, Jordan.
Glad to have you. The first question I'd like to pose to you is, what are you currently doing, or what have you ever done to advance the public interest, and why?
Well, I currently, as the CEO of MedChi, which is the Maryland State Medical Society, we focus on our mission is to be the foremost advocate for physicians, patients, and the public health of Maryland. So we work on things like making sure that Medicaid is funded appropriately and making sure that people have access to health care and issues that generally affect the public health. And that's something where it makes me feel good that I'm working for physicians, but I'm working really more for the public health. And in the past, I served as an elected official for 2 terms in Queen Anne's County, and I've served in various different roles on boards and commissions. And interestingly, even right now locally, I'm volunteering. I'm a local member of a liquor board, looking out for the public with regards to regulating licensed beverage. So I'm still somewhat in public service.
So I can see that liquor board is clearly related to your interest in public health. However, originally you are an attorney with a law degree from the University of Baltimore. How is it that you segued from a private practice attorney and a political career over to one where you're really an advocate for public health, which is not an area where you had formal academic training?
Right. So it's kind of funny. When I was coming out of law school, it was difficult. I had trouble finding a job, and I didn't know what to do. And I took a grant position at MedChi, where I work today, back in '96. And I was a young lawyer, and I was doing this grant position, and I was practicing law with a gentleman named Steve Fogelman, who was my law partner, and I was doing both things. And when a new CEO took over, who had a real passion for advocacy, he said, maybe we could do something a little different. And he moved me over to the general counsel's office, and I was kind of doing both, and I started running for office. But I started working for MedChi, and while I was working here doing relatively low-level stuff, I started really appreciating working on healthcare issues, thinking about health system reform and Medicaid and how we treat people and how we make sure that folks have access to healthcare. And I just really took a liking to it. And I had worked for the Medical Society in one capacity or another for 20 years as of last September. So it was one of those strange twists of fate that brought me here.
So 2 decades of experience in advocacy within the medical public health arena is something clearly you've become quite knowledgeable about, and it sounds like you've become quite passionate about it. What really has been driving you through this process? What are some of your real values and priorities that are saying, look, every day I need to get up and I need to advocate for these changes in the state legislature?
Well, this has been a really exciting time for healthcare because we've had the advent of all the discussions. When I first started working here, a little bit about Hillary Care. We were near the end of that kind of not working out. And then I got to be here during Obamacare, and now we get to see whatever President Trump is going to do, whatever that is. So we've had a period of change. And I think the reason it's so exciting in my mind is that I fundamentally believe that everybody should have access to health care. And I think most people believe that, regardless of the party or political persuasion. And the key is how do you pay for it and how do you create it. And we've been going through this period of the last 20 years, essentially, where we've been trying to figure out how to increase access as a country and as a state, and working on that and figuring that out and looking at different ways to do it is something that I'm very passionate about. I mean, people should have access to quality health care, one of the richest countries in the world, and there's no reason we can't do it. And we spend a lot of money on health care, and we don't always get the best result for that spend. And so I think the idea of payment reform and figuring out how we actually make sure people have access is something that's very laudable and very worth working on, and it's important to me personally.
So you say that we're one of the wealthiest countries in the world, and yet we're one of the few developed nations in the world that doesn't have universal health insurance coverage, and yet you add to that we spend quite a bit more. In fact, the reality is we spend about twice or double what any other developed nation spends per capita on healthcare in the world. So the question is, well, if everyone agrees, regardless of their political affiliation, that healthcare is something that most Americans ought to have access to, and that the real trouble is finding out a way to pay for it, why is it that we're spending? I mean, it's almost illogical that we're spending more money than other countries, but have a lesser proportion of our population covered. How can that be?
Well, I guess the thing, and I've said this before, it's almost like we've got the worst of both systems. You know, we have some things that make us more like a socialist or single-payer type system, and then we have other things that make us like a pure capitalist system for healthcare. But and it all kind of mixed together, and we have all the inefficiencies of the socialist system with all the kind of inappropriate incentives of the capitalist system. And we kind of have to make a decision as to what we want to do as a country, and kind of figure out, do we want to have a purely capitalist system with some type of protections in place, or do we want to go to a single payer type system? And I actually believe, and maybe this is Pollyannish, but I think that intelligent policymakers can make either one work. But unfortunately, on a national level, because it's very difficult for people from different parties to kind of work together or try to solve things, we don't fix problems. You know, we never really were able to take the time to fix the problems with Obamacare. We don't solve problems. Instead, we vilify and fight one another, and we can't work through these things. It's very frustrating.
So a lot of solutions, well, let's go with this. States are often referred to as the laboratories of a democracy. If you do look at the Affordable Care Act, you'll find that many elements of it incorporate previous successes with state-level legislation, notably Mitt Romney's Massachusetts Health Benefits Exchange and universal health insurance coverage with an individual mandate. Now, you advocate primarily as the CEO of MedChi, you advocate within the Maryland General Assembly, which is you advocate for state-level solutions. Now, so often in the healthcare landscape, we talk about national solutions. Can you talk a little bit about what Maryland does right, what the solutions are that you've been advocating for in Maryland, where you see the path forward in Maryland, and what you've tried in the past and been successful with in making healthcare reform, successfully executing healthcare reform in the state of Maryland?
Well, one of the things I think that Maryland does well and different from every other state in the country is we have something called a unique Medicare waiver, and this is something that I spent a lot of time working on. As a result of this waiver from CMS, Maryland gets funding to hospital systems differently than the rest of the country.
You for a second. CMS, for our listeners, is Center for Medicare and Medicaid Services, which is a federal health insurance entity that provides health insurance to the elderly and the poor. Continue.
Right. Sorry about that. I'll watch the acronyms. Healthcare is amazing with the acronyms too. The one that always messes everybody up is HIE, because the HIE can either be the Health Information Exchange or the Health Insurance Exchange. So we're so acronymed out in healthcare that we actually are using the same acronyms for different things. But anyway, back to this. So Maryland has this unique payment model, and essentially hospitals in Maryland, unlike in other states where hospitals go out and negotiate with insurers and work with the state on Medicare and Medicaid, in Maryland they don't do that. They're on global budgets, and their payment system is set through something called the Health Services Cost Review Commission that determines how much money the hospital gets. And this allows for money to be available for things like graduate medical education, capital improvements, and it means we have a more robust hospital system. But it also means there's incredible certainty in the cost. And I think this is a model that, if it could be further developed and expanded out in other areas, it could really change the way healthcare is delivered nationally. It has worked well in Maryland. It has created stability. We have some of the best systems in the country with regards to Hopkins and Maryland, University of Maryland Medical System. And it's been a big success, and that's an example of something that we have here uniquely in Maryland that we've worked on and developed through the General Assembly and through the Department of Health and Mental Hygiene. That could be something that could be a model for how we deal with healthcare in other places.
So Atul Gawande of the New Yorker is famous for citing data produced by the Dartmouth Atlas Group that basically says there's huge price variation around the country, and they use the famous example of McCann, Texas, which is quite expensive from Medicare's perspective. When you speak about the HSCRC, which again is the Health Services Cost Review Commission, all-payer rate setting system, meaning that all health insurance companies pay the same price for every single procedure in the same hospital, would you say that that is a solution for bending the cost curve and reducing incredible pricing variance that you see in the other 49 states?
And I think it is, and I think it's a success story. The issue is that needs to be looked at that hasn't quite been resolved is the part of healthcare that is not included in that. So in Maryland, the way it works is you have that way. You have had the bending of the cost curve on that side. If you look on a per unit basis, we've clearly had that compared nationally on the hospital side. But the issue is that the non-hospital side is not always well integrated with it. And the key is, and this is something that we spent a lot of time when we were working on very hard for the last 10 years, how do we integrate the private, the nursing homes and the private physicians and the folks that are not in the hospital system, that are not on these global budgets? How do we integrate that in, and how do we work together? And the key is figuring out how to do that. And that's something we spend a lot of time on. If we can figure that out, it'll work even better. But I do think it's something that's worth putting the time and energy into tests and to see, how to make this work. I think it's been a big success for Maryland on the hospital side, and if we could figure out how to integrate the other piece of healthcare that's not in it with it, it might be a tool that could be used nationally down the road.
Now, you talk about global budgets, but yet the all-payer rate setting system still is primarily fee-for-service driven. They'll say if you have a carotid endarterectomy, it's going to cost $7,000 to be done at Hopkins Bayview Hospital.
Mm-hmm.
Like, that's how explicit it is. The global payments that you spoke about earlier is basically saying if you have a cardiac arrhythmia, then the hospital will get paid $15,000, and they need to make sure that and then you shift all responsibility to them, and any readmissions that you may have to the hospital in the next, 30 days or so, you're on the hook for. How do you translate the current all-payer rate setting system, which is fee-for-service driven, to a more global payment system, which is the national trend?
Right, but remember, even though there are those global budgets on those specific procedures on the hospital side you talked about, there is also a global cap for the entire system, and there's a global cap for each hospital. So there is truly, really a control mechanism. I think one of the biggest problems with that system is we have to be careful that as we implement it, it can create some bad economic incentives where hospitals might be incentivized not to provide care. We haven't really seen or heard a lot of stories around that. We've heard a couple anecdotal things here and there, but there doesn't seem to be any trends yet. The global budgets are relatively new in Maryland. It used to be it was totally fee-for-service driven through the rate setting system. We've had the waiver on the rate setting system for since 1977. But now that we've gone to a pure global budget, we haven't seen this, but we could have, like I said, perverse economic incentives, and that's one of the things we always have to work on is figuring out how do you provide care and measure costs without rationing or causing people problems or creating unintended consequences. And those are kind of those complex questions that we have to work with every day.
Now, can you elaborate for our listeners about what rationing is and the difference between need-based rationing and cost-based rationing?
Well, I mean, I guess rationing is in the eyes of the beholder, whether it's need-based or cost-based, right? Essentially, the question is when you put any type of system on a global budget, you put it on constraints, it is clear that there can be time delays in getting service, or some people just might not get it. And that's the reason that many hospitals in America have folks from other countries coming here to get services. And it's one of the issues that has to be dealt with as you move into a more regulated system, particularly when you move into one where there are caps on costs. And you have to figure out how to manage that and what's appropriate.
So a lot of MedChi's members, some of MedChi's members are physicians who accept Medicaid beneficiaries. For our listeners, again, Medicaid is the federal state partnership program that provides health insurance to the indigent, which is the poor. So the question is, when you've seen a vast expansion of Medicaid eligibility both in 2006 in the state of Maryland and further expanded under the Affordable Care Act, you find that Maryland's health insured rate is above 90% of the population, perhaps even more than that.
It's a little higher, actually.
it's like 95%, and it's only about 5% or so is uninsured. So when you see greatly the diminishment of the uninsured population, you turn to hospitals and you say, well, all your hospitals and health insurance companies are not-for-profit, which means they have to provide a community benefit that's approximately equal to 5% of their total annual revenue. And that community benefit is traditionally provided in the form of uncompensated care to uninsured individuals. What has been the effect on healthcare, medicine, and medical practice, both in the ambulatory setting, which for our listeners is outpatient or just seeing your doctor, and or the hospital, in seeing a greatly diminishment of the uninsured, and therefore, has there been any change in how community benefits have been provided? And I guess let's start there.
Well, I think there's two issues there. One is the expansion of Medicaid. Let's talk about that first. In Maryland, we now have over 1 million people on Medicaid in Maryland, and the expansion has been really important. Hundreds of thousands of new people were able to sign up for Medicaid, and that's great news. Let me also say that in Maryland, compared to a lot of our sister states, we have a much higher participation in the physician community. One of the reasons we have a much higher participation is when Barack Obama passed the ACA, the legislation actually increased physician payment in Medicaid and allowed for the General Assembly to have additional funds from the federal government to do so. And fortunately, there was a large increase which happened in their payment, and doctors were paid fairly for seeing Medicaid patients. Unfortunately, Governor O'Malley cut that payment significantly right before he left office. The General Assembly and Governor Hogan has returned some of it, but not quite all of it. But we're still paid at 94% of Medicare for Medicaid patients. The doctors take Medicaid, and that's a big deal because it's one thing to promise somebody health insurance. It's another to make sure they actually get it. And Medicaid patients in Maryland can sue, in most cases, a physician if they need to. We don't have major shortages or major network problems, and we have a large number of insurers who provide Medicaid. They call them MCOs, or managed care organizations in Maryland. So that's another big positive in Maryland. Now, your second question about the uncompensated care that is provided by Maryland hospitals, and one of the conditions of this global budget model, this rate-setting model that we've been discussing, is that they do provide uncompensated care, which is wonderful. And the amount of uncompensated care has gone down. That issue has begun to be addressed and talked about. And the hospitals are going to have to explain what they are doing with that money from a community benefits assessment, as less and less people who don't have insurance are coming in and they're getting paid for the uncompensated care. They're going to have to provide other community benefits. And as those plans get filed, they're going to explain what they're going to have to do. And that's a very interesting question going forward. That's going to have to be answered by the hospitals.
Because the question is, are there tax implications? When you talk about wanting to improve access, right, you're saying we need to both insure the population and ensure that a sufficient array of medical providers are willing to accept these newly insured patients and actually see them. And that's what you spoke about when you said network access. So the big problem with you said O'Malley, Governor O'Malley of Maryland, former governor, instituting cuts to Medicaid reimbursement rates is that they're insufficient funds, right? The taxpayers can only pay so much. So then when you look at these large billion-dollar corporations, which are nonprofit organizations such as Care First, which is a health insurance company, or Johns Hopkins Medicine, you think, well, gosh, what's the corporate income tax rate that these multi-billion-dollar organizations are paying? And in fact, the corporate income tax rate they're paying is zero because they are not-for-profit. So is there any discussion about and obviously if they were to be taxed, that would provide funds that could improve accessibility and remuneration rates. So what's the discussion? Is there any discussion or threat to the nonprofit status of hospitals and health insurance companies, or is the IRS not even going there?
Well, actually, interestingly, I think really there's a local and a state and a national answer on that. On the national level, I think you have seen a real look at these companies. Particularly, I believe, didn't Care First in California run into a little trouble with their nonprofit status. So I think you are seeing some people nationally look at that and ask those questions. Locally, I haven't heard much on the nonprofit status of hospitals or other nonprofit entities as part of a solution. And frankly, in fairness, we do need to remember that uncompensated care is just one of the things they provide that make them a nonprofit. They have missions, they do things, they do provide reduced care, and they do other things. So there's a lot of complexity around that. And let me say, Governor O'Malley took the rates for Medicare from 100% to 87%. So it wasn't just a cut. It was he took the Medicaid rates that were equal to Medicare at 100% from 100% to 87%. So that's a pretty big draconian cut all in 1 year. Exactly the reason it had to happen was because as a result of the way the budget was managed in Maryland, there wasn't enough funds to pay it. And I think those are legitimate questions to ask, and we need to decide where we're paying for folks. But I would argue this is one of those things where when you cut Medicaid rates and then physicians and FQHCs and other healthcare providers aren't willing to see those patients, they end up going to more expensive settings, and it ends up costing the system more money in the long run. And I think sometimes with healthcare particularly, we look at things at short run costs instead of long run costs. And it's not just the public people who do this. I think that some of the insurance companies who are more focused on their quarterly profits than their long-term profits do the same thing, because they're driven economically to worry about those quarterly profits, and they make decisions to deny care using prior auth procedures or step therapy or other tools to deny care because they want to keep costs down or keep numbers good for the quarterly profits. And one of the major problems we have in healthcare, both on the public sector and on the private sector, is this inability to look at the long-term costs and the long-term implications of actions.
So, Gene, we've covered a lot of ground in the healthcare arena. I'd like to segue back into your other forms of public service on the Liquor Board and formerly on the Queen Anne's County Commissioners Board. Can you talk a little bit about the value that you add there and why you consider it to be valuable for you to use your very pressed schedule and your very limited amount of time to serve on the Liquor Board and to serve on the commissioners, both of which you were able to do and are able to do while concurrently holding a job with MedChi?
So when I was on the Queen Anne's County Commissioner, I was a lawyer for MedChi. I wasn't in charge or anything, so it was a little different. Being a county commissioner, have always been interested in politics and public service. I've been elected to the Democratic Central Committee before I was elected as a commissioner. And in fact, I'm the last Democrat to get elected in Queen Anne's County. It's a very Republican county, very conservative county, and I still live there. I grew up there and I love the place, and I really enjoyed serving. I ran principally not only because of my love of politics, but also because I felt that the county commission and the county was being controlled by special interests, particularly developers, who are being allowed to do whatever they wanted to do with unfettered access to just do anything, not considering the environment or anything else. And when I got in there, I really had an opportunity to make some changes and try to make the county a better place and preserve land and things in, and it was something I cared about. I still live there today. My kids go to school there. I love Queen Anne's County. It's a great place. And even though the current board are Republicans, I'm friends with a few of them, and they asked would I be willing to help serve, and they had an opening on the Liquor Board, so I took it when they offered it to me. I thought it was very kind. And I'm enjoying that, working on, regulating the licenses and making sure they're not selling alcohol to minors and some of the public health issues there. But it's a place where I live, and it's a great place to be, and it was really an important part of my life. One of the most important things I did when I was there is I worked with then State Senator E.J. Pickton, who was a Republican, and the two of us worked together to build the emergency room in Queenstown. We were one of the only two counties in Maryland without a hospital. So getting that freestanding emergency room built was a major accomplishment. I did some other things that I'm really proud of when I drive around the county and look and say, I helped make that happen or help make a difference. And I think it's something everybody should do something with regards to public service, because it does make a difference in society. I think it's something we should all do and strive to do.
So as we approach the end of this podcast, I'd like to ask you to take a moment to opine on why making a difference matters. You have clearly been making a difference as an advocate in the legislative arena, in the Maryland General Assembly, as the CEO of MedChi, changing the healthcare environment to advance the interests of physicians and other providers. You have been in elected office advancing the public interest. Why is it that making a difference for the better is something that's worthwhile? And after the end of your career, if you could look far into the future, what kind of legacy do you hope to have created throughout the course of your career, and what kind of differences do you hope will be lasting because you were able to make the contributions that you have made?
Well, I hope, I think I'll answer the hope question first because I think it's the most important one. I hope at the end of my career, people look back and say that Maryland and Queen Anne's County and the places where I've lived are better places because I was there and that I made a difference in making things a little better for everybody. When I made a decision to get involved in public life, some of it was because I liked politics and I enjoyed the art of it and working with people and talking to people. But a lot of it too is that I see things changing in a way sometimes that I don't like them to change. When I was a young man growing up in Queen Anne's County, you could ride your bike anywhere, you could go swimming in Cabin Creek, you could do these things, and you see the farm fields that I used to ride my bike by becoming developments, And I look around and I see people in the healthcare world who don't have access to care, who should have access to care. Folks who live literally a block away from some of the best institutions in the world in Baltimore City don't have access to a primary care doctor. We need to change that. So I think one of those things that we should all do is say, what do I like about where I'm living and how do I protect that? And what do I don't like about where I'm living and how do I change that? And if we all try to change something, maybe even something that's little, it makes a difference in all of our quality of lives and who we are. And that's what I hope people say when they look back. And that's why I think it's important to be involved in public service in one way or another. And obviously things like sitting on the liquor board to look at 30 or 40 licensees in Queen Anne's County, a very small number, to try to keep them from selling alcohol to minors isn't that big a deal and isn't really that important in the scheme of things. But it is important for that one minor who doesn't end up doing something stupid. So, if you can't do big things, doing little things to make a difference. And it's worth putting the time in to do it.
So that has been Gene Ransom, CEO of MedChi, the Medical and Chirurgical Faculty of the State of Maryland, and the former president of the board of Queen Anne's County Commissioners, who speaks about his lifetime in public service as a means of making a difference, really almost according to common sense, where common sense is lacking. He speaks about holding developers accountable. He speaks about expanding access to health care, especially to those who live right next to world-class healthcare institutions. He speaks about having compassion for those without, but also he reminisces about a time when there was more green and more opportunities for kids to be kids or be safer and without development encroaching in all the natural resources. Gene is somebody who really can get into the weeds but doesn't lose the larger perspective. He serves as a CEO of MedChi as a means of trying to say, look, I understand where Maryland is within the country and where Maryland is in the world. And we can be leaders in certain things, but we also have to come to grips with the fact that we are really a little bit behind the eight ball in a number of other things, particularly with containing costs. And he's willing to take different innovative solutions from around the country within Maryland and try to expand it for what seems to be common sense solutions in a world that often is somewhat has a dearth of common sense. So, Gene, thank you so much for joining us today.
Thanks for having me. It was a lot of fun.
And this has been episode 120 of Public Interest Podcast with your host, Jordan Cooper, where we interview politicians, activists, advocates, and others who seek to improve the state of the world. We ask that you subscribe to the podcast on publicinterestpodcast.com. You can listen on iTunes or on your podcast app on Apple products. Should you wish to communicate with Gene, you can leave a voicemail. The phone number is on the Contact Us page of the website. That voicemail will be sent over to Gene. We appreciate so much your time listening to us, and we'll talk to you next time. Bye.